Welcome to this explainer. Today, we're diving into something absolutely mind-blowing. We're looking at a truly audacious medical achievement, cardiopulmonary bypass. It is quite literally the closest we've ever come to temporarily pausing human life purely for the sake of saving it. So let's get right into exactly how this medical marvel actually works. Okay, let's dive into this. Just imagine the terrifying, almost impossible physiological puzzle that surgeons were staring down just a century ago. How on earth do you repair an intricate, super delicate organ that is constantly moving, constantly pumping under high pressure, and, well, full of blood? To do any kind of delicate intracardiac repair, a surgeon absolutely needs a perfectly still, bloodless field. But here's the ultimate surgical catch-22. If you stop the heart, the patient instantly loses oxygenated blood flow. And without that, the brain and other vital organs begin to die within minutes. Well, the breakthrough finally hit in 1952. That was the year Dr. John Gibbon pulled off the very first successful human cardiac surgery using a mechanical bypass machine. He used it to repair an atrial septal defect, basically a hole in the heart. By taking the blood and rerouting it completely outside the body, he proved that we could bypass the heart and lungs entirely. He kept the patient's organs alive and happy while the surgeons safely worked on the heart itself. A total game changer. So this whole process is formally called cardiopulmonary bypass, or CPB for short. You'll also hear it referred to as perfusion. Basically, it's the medical technique of using an extracorporeal circuit, literally a machine sitting outside the body, to temporarily take over both the circulatory and respiratory functions. And while a surgeon is hyper-focused on repairing the heart, the real unsung hero of this entire operation is the clinical perfusionist. Think of the perfusionist as the pilot flying a highly complex biological aircraft. They're the ones managing this heart-lung machine, meticulously monitoring the patient's vital signs, blood chemistry, and temperature while the patient's biological heart is completely stopped.
So here is our surgical pre-flight checklist. We're going to navigate through stopping the heart safely, inside the bypass circuit, the chemical balancing act, managing temperature and chemistry, waking the heart up, and finally navigating the risks. Section 1, stopping the heart safely, electromechanical arrest.
Okay, so first things first, we have to intentionally stop the heart without actually killing the precious tissue. To do this, the aorta has to be cross-clamped, which completely cuts off the heart's own blood supply. Now, obviously, this renders the heart ischemic, meaning it's starved of oxygen. So to protect it, our perfusion pilot swoops in and delivers a solution called cardioplegia. This stuff is a profoundly cold, high-potassium fluid that gets delivered straight into the coronary arteries. The potassium induces what's called electromechanical arrest, totally stopping the heart from beating. Meanwhile, the extreme cold dramatically drops the heart muscle's metabolic oxygen consumption. By just plummeting its need for oxygen, that cardiac tissue can safely survive being completely disconnected from its blood supply. Section 2. Inside the bypass circuit, the blood's heroic journey. Let's move along and see how this builds into a fascinating closed-loop journey for a single drop of blood once bypass is officially initiated. First up, we've got venous cannulation. Large plastic tubes are placed in the right atrium or venae cavae, allowing the oxygen-depleted blood to just passively drain right out of the body using good old gravity. This blood then pools in a venous reservoir. Think of this as a staging area where fluids or medications can be easily added. From there, the main pump takes over. This is our artificial heart, forcefully pulling blood from that reservoir and pushing it forward. Next, the blood enters the oxygenator, our artificial lung. As it flows across these microscopic hollow membranes, carbon dioxide is scrubbed right out and fresh oxygen diffuses in. Finally, in arterial cannulation, this beautifully oxygenated blood passes through a microfilter and is forcefully pumped back into the systemic arterial system, usually right through the ascending aorta. Now, to actually mimic the heart's natural pumping action, we rely on two main types of artificial pumps. The classic roller pump literally uses rotating arms that physically compress or squeeze a length of tubing to push the blood forward. And hey, it works well, but that physical squishing can cause hemolysis, which is the destruction of red blood cells over longer periods of time. On the other hand, we have the centrifugal pump. Instead of crushing tubes, this one uses rapidly rotating stacked cones and magnetic kinetic energy to create a pressure differential that gently propels the blood. Because it relies on fluid dynamics rather than sheer crushing force, it preserves blood platelets and protects renal function. So for those really long surgeries, it's a much better option. Section 3, the chemical balancing act, preventing massive circuit clots. We have to pause here for a second because there is a severe danger we need to talk about. Human blood is biologically hardwired to clot the very instant it hits an unnatural surface. So pumping a patient's entire blood volume through meters of synthetic plastic PVC tubing, that naturally triggers massive, life-threatening clotting. To stop the entire circuit from just turning into solid plastic, we have to monitor what's called the activated clotting time, or ACT. Now, a normal person's ACT is about 80 to 120 seconds, but before the patient is ever even connected to the machine, the perfusionist has to administer absolutely massive doses of unfractionated heparin. We're talking around 300 units per kilogram. They do this to push that clotting time way out, well beyond 480 seconds. And they are constantly verifying this metric to make absolutely sure the blood remains completely liquid. But think about it. Once the surgical repair is complete, we're left with a patient whose blood fundamentally cannot clot. And for a surgical wound, that is disastrous. So reversing the process is absolutely critical. Post-bypass, our perfusionist carefully administers a drug called protamine. They give it super slowly, over about 10 to 15 minutes. Protamine chemically binds to and neutralizes the heparin at a very precise ratio of somewhere between 1:1 to 1:3. This meticulously restores the blood's natural ability to coagulate.
Section 4. Managing temperature and chemistry. Cold and calculated. To further protect the patient's organs during surgery, especially the brain, we actually induce hypothermia. Cooling the body safely decreases the overall systemic metabolic oxygen demand. It makes sense, right? But cooling the blood actually changes its foundational physics. Carbon dioxide becomes highly soluble, which drops the partial pressure of CO2 and causes the blood to become alkaline. So the perfusionist has to actively manage this using two distinct strategies. In the alpha-stat strategy, the blood pH is simply not corrected for the temperature change. We prefer this for adults because it allows the brain to maintain its own natural autoregulation of microblood flow. Conversely, in the pH stat strategy, the perfusionist actively adds CO2 right into the oxygenator to force the pH to remain constant. This intentionally dilates the blood vessels to increase cerebral blood flow, which is a highly protective strategy for infants undergoing deep hypothermic bypass. Section 5. Waking the heart up. The weaning process. All right, so the surgery is complete, the heart is repaired, and now we've got to execute the weaning process. This means withdrawing mechanical support so the biological heart can take back over. So the crucial point here is that waking the heart up is a highly choreographed sequence. First, we undergo gentle rewarming. The core temperature is raised very slowly, strictly avoiding cerebral hyperthermia, which can cause severe brain injury. Next up is de-airing. The team uses echocardiography to ensure absolutely no tiny air bubbles are trapped inside the heart chambers, because if they are, they could cause major arrhythmias. Once the aortic clamp is finally removed and blood hits the heart muscle, it often wakes up in a state of ventricular fibrillation. So the surgeon uses internal paddles to deliver a quick 5 to 20 joule electrical shock to defibrillate the heart back into a normal sinus rhythm. Finally, as the pump flows are incrementally dialed down, medications like vasopressors and inotropes are given to help that newly repaired heart pump against the body's natural vascular resistance. Section 6. Navigating the risks. High-stakes complications. Look, a cardiopulmonary bypass is essentially a massive assault on the body's natural state, and our perfusion pilot is highly trained to handle some intense turbulence. Let's briefly look at these high-stakes risks. Mechanically speaking, cannulating the vessels carries real dangers, like aortic dissection, or even pumping a massive air embolism if the reservoir accidentally empties. Hematologically, as we mentioned, passing blood through synthetic tubes damages platelets, creating genuine bleeding risks. Systemically, the body actually recognizes the machine as foreign. This triggers a massive systemic inflammatory response and alters blood pressure, which can lead to acute kidney injury. In severe cases, patients can even experience vasoplegia. That's a state of massive vascular dilation that totally resists normal drugs, requiring the team to administer specialized rescue medications, like methylene blue, just to restore blood pressure. But despite all these risks, the sheer fact that we can even achieve this is just awe-inspiring. Decades of engineering, chemistry, and understanding human biology have culminated in our ability to literally pause human life, open the chest, repair the engine, and start the whole shebang back up again. It requires absolutely unparalleled teamwork between the surgeon, the anesthesiologist, and our pilot, the perfusionist. As we wrap up this explainer, I really want to leave you with this provocative thought. If we can already perfectly mimic the heart and lungs to suspend life today, as medical engineering and biocompatible materials continue to evolve, what unimaginable limits of human survival will we conquer tomorrow? Thank you so much for exploring this with me.